Okay. Welcome everybody to our grand rounds for today. Today we have Dr. Richard Kim from London area presenting. He is a professor and chair of the Division of Clinical Pharmacology in the Department of Medicine at the University of Western Ontario. He went to school in Saskatchewan before going to Vanderbilt University, where he rose to the ranks of a full professor by 2004. In July of 2006, he moved his team to the University of Western to lead a program in translational and personalized medicine research. Welcome.
Great. Thank you so much, Kathy. And I thank the committee for going over potential speakers and having me present on this topic of personalized medicine, and specifically to kind of go over implementation of personalized medicine, because this is an area of rapid development, but people sometimes wonder, where are we now and what's clinically doable? So I'll kind of review our program, and then I think at the end we'll have some time for questions. So this is just my disclosure, noting that I do have various grants from various funding agencies. The learning objective is outlined here, particularly focused on defining clinically meaningful pharmacogenetic tests and to describe recent advances in pharmacogenetic testing. So let me kind of give you kind of a rough idea as to some of the approach that we have here at London Health Sciences Centre in Ontario, in London, Ontario. As part of our personalized medicine program, we do actually carry out a lot of genetic analysis, what we call genotype testing. In addition, I won't talk about so much today because of time issues, but we do measure a lot of drug levels as a way of better understanding drug concentration and drug metabolism. So this is a slide just to show that within our medical center, that personalized medicine is kind of viewed as a regular part of patient care. So you can even see there's actually signages that tells you where one might find a personalized medicine clinic. In terms of processes, we do have a clinical consultation process in which physicians from various specialties, as well as primary care, refer their patients to us. And then patients are seen in our clinic. We carry out the consultation process, provide some patient teaching material. We typically have physicians as well as residents and pharmacists. And depending on the type of medications or testing, sometimes we do ask our patients if they would participate in research. And if that is the case, we do have our research coordinator that obtains informed consent. We get a blood sample for genotype testing, as well as sometimes patients complete some patient surveys. With regards to providing personalized medicine patient care, we do have various type of technologies that we have created, working with our hospital ITS, so that things that we do are in fact secure and behind the hospital firewall. That does help our clinical folks with regards to logging and tracking samples and uploading pharmacogenomics data, as well as generating custom reports. So the focus of our team has always been this notion of why do people vary in response to medications? So this is a slide that shows two identical people getting identical dose of the medication. But if you could measure blood concentration, you might see the person on top might have a blood level that is significantly higher than the person at the bottom, even though both receive the same dose. And if this were an antihypertensive medication, the first person on top, the blood pressure might be quite low, whereas the second person, the blood pressure response might be normal. We know that drug metabolism is carried out predominantly by a set of metabolizing enzymes that are typically referred to as cytochrome P450 enzymes. And people always think there's like hundreds of these enzymes that break down medications, but it turns out only a handful of drug metabolizing enzymes break down most of the drugs that we prescribe. And you can see that by understanding even a few of these enzymes, you can kind of tell, which drugs might be affected. And some of these enzymes are known to be genetically variable. So if you look at some of the FDA approved medications, over 300 drugs actually have some information in the product monograph about potential role of pharmacogenetics. But we find that most people don't really know what to request because they don't know too much about the metabolism pathways, and it's not really something that is expected to be known. Although I think certainly some of the pharmacists may be more aware, but I think in medical schools pharmacology teaching may not be as optimal and may require a bit more teaching, and in addition to some of the pharmacogenetic information that is becoming more widely known. But let me go over with you just a case and with some kind of a example of the things that we see. And I suspect many of you probably don't have this type of case too often, but this was an inpatient medicine team that asked my team to carry out pharmacogenetic testing for an 87-year-old on 200 milligram twice a day dose of metoprolol, which is a beta blocker, for heart rate control in the setting of atrial fibrillation. The patient had been admitted to the orthopedics floor after a hip fracture. So really the question that one could ask is, what test would our internal medicine team ask of our team? So what would they ask for? This enzyme called CYP3A4, or this one called 2C19, or CYP2D6, or CYP2C19 and 2D6? They actually were very specific. They wanted CYP2D6 testing because they knew it affects metoprolol metabolism. So as you know, metoprolol typical dosing is 25 to 50 milligram twice a day. So the medicine team that was looking after this patient found it very difficult to believe that an 87-year-old was taking 200 milligrams twice a day. So they attempted to lower the dose of metoprolol to 100 milligram twice a day. And when they did that, she promptly experienced a tachycardia that subsided when the dose was increased back to 200 milligram twice a day. And because of that, the team had asked us to carry out CYP2D6 genotype testing. So for this type of patient, what kind of result would you expect? Normal metabolizer, poor metabolizer? It's a trick question. Or an ultra-rapid metabolizer? So the answer is you would expect she might be an ultra-rapid metabolizer. And so we had seen the patient in consultation, obtain consent for CYP2D6 genotypes testing by my research laboratory, and there was really no cost to the patient for us to do that. And the patient turned out to be a CYP2D6 ultra-rapid metabolizer. And in those patients, they are predicted to require a very high dose of metoprolol. But in this case, we simply thought it would be better to recommend a change in her beta blocker to bisoprolol, which is not affected by CYP2D6. So she's in pain from her hip fracture. So your colleague suggests Tylenol number 3, essentially, this combination, acetaminophen, caffeine, codeine. What would you do? Would you give her a higher than normal dose? You'll start her on normal dose. You wouldn't bother with that. And you would rather use tramadol instead, or do not start her on Tylenol number 3 or acetaminophen, caffeine, codeine combination, or tramadol. So the correct answer is you would not start her on those medications. Why? Because codeine is actually not a useful pain medication. It's actually converted in the liver to its active metabolite morphine, and its conversion is highly affected by the presence of this enzyme CYP2D6. But in this case, a patient is an ultra-rapid metabolizer, so she would have a greater ability to convert codeine to morphine. So in fact, she would be at risk for excessive opioid response. So that codeine-containing medications may lead to too much of an opioid response. And the same is for tramadol. Tramadol is what we call a prodrug that is converted to the active metabolite that provides analgesic pain relief, and it requires CYP2D6. In this case, because she's an ultra-rapid metabolizer, she might make too much of the active metabolite of a codeine, and that she might get too much opioid effect from tramadol or codeine. Now let's look at another case that may be of more relevance to cardiology. So this is a 65-year-old male with history of coronary artery disease as well as previous STEMI that has a drug-eluting stent, presents to the ER with a syncopal episode, and because he was doing poorly, they decided to hold clopidogrel for 5 days. But then came back a week later with an actual STEMI, taken to the cath lab, and the patient was found to have an in-stent thrombosis, and this was successfully restented. A patient was to start aspirin and ticagrelor, but there was a bit of concern about an apical thrombus, so the patient was started on apixaban, clopidogrel, and aspirins. And that day, the inpatient team asked us to see this patient. We saw our patient around 9 o'clock, and we carried out CYP2C19 genotype testing. Cardiology was hoping to discharge the patient within a few hours. Patient was also on a statin medication with a previous history of some statin myopathy, certainly back pain, and had been started on Rosuvastatin. So we obtained consent for pharmacogenetic testing. We carried out pharmacogenetic testing in CYP2C19 and this transporter called SLC01B1 that is related to statin disposition. We completed the testing within 2 hours. And when we did the 2C19 testing, the patient was predicted to be an intermediate metabolizer. And we know CYP2C19 intermediate metabolizers do not generate an adequate amount of the active metabolite of clopidogrel. For statins, the genotype was noted to be normal. So once we had the result, our resident contacted the inpatient cardiology team to consider switching to ticagrelor instead of clopidogrel. And the cardiology team decided to go with ticagrelor plus aspirin plus apixaban for the first 3 months, then reassess whether the apical thrombus has resolved, and then consider discontinuation of aspirin, or consider ticagrelor plus apixaban if a thrombus is still present to reduce the risk of bleeding. And we got the patient out of the hospital by 3:50 p.m. that day. So that's kind of an example of the turnaround time that is very helpful, given all the hospitals tend to struggle with census and wait times in emerge. So this is a slide that shows you clopidogrel metabolism. It's a little bit busy, but basically clopidogrel is inactive. It actually requires a conversion to its active metabolite to act as a antiplatelet agent. And the formation of the active metabolite requires this enzyme called CYP2C19. We now know that patients who have loss of function genetic variation in CYP2C19 are more likely to have adverse effects from taking clopidogrel, particularly with regards to the risk for stent thrombosis. And more recently, a large study published in New England had demonstrated that, in fact, a genotype-guided strategy for selecting clopidogrel versus other antiplatelet drugs such as ticagrelor or prasugrel is, in fact, a good idea, particularly for patients who are CYP2C19 normal metabolizers. So this showed that, in fact, patients who are CYP2C19 normal metabolizers, their outcome was no worse compared to ticagrelor, and that if anything, there tend to be a trend towards less adverse effects, including bleeding. So the authors concluded that genotype-guided dosing of clopidogrel versus other antiplatelet drugs is, in fact, non-inferior to just starting everybody on ticagrelor. I'll show you just a little bit about statins, because the patient, we also provided some guidance on statin dosing. Statins are not, most of the modern statins are not major metabolism. It's actually transported in the intestine, as well as especially in the liver, by these drug transport proteins. Many years ago now, our group was the first to identify a genetic variation in a statin transporter that is currently called SLC01B1. And we had predicted that genetic variation might affect all the drugs that this transporter transports. And interestingly, a large study published in the New England in 2008, where they looked at patients who had struggled with muscle pain or injury on high-dose simvastatin compared to patients on the same dose of simvastatin who did not experience muscle issues. They did what is known as a genome-wide association study, and they found one genetic marker that was highly associated with the risk of statin myopathy. And it turned out this genetic defect was the same genetic marker that our team had identified back in 2001. So basically, if you're homozygous for this genetic variant, that your risk for myopathy symptoms were nearly 15 times higher compared to those who had the normal wild-type allele. And if you were heterozygous or just carrier of the one variant allele, that it was about 3-4 times higher risk. A number of years ago, our group published some data that shows you kind of an easier way of predicting a dose of drugs such as rosuvastatin and atorvastatin. And we found out that genetic testing in drug transporters such as SLC01B1 and ABCG2, in addition to considering things like age, might give you a rough idea of what a optimal maximum dose of a statin may be for patients if you don't want to exceed certain blood level of the statins. So we believe high statin levels in blood is a risk factor for having muscle injury. So next couple of slides, just a very brief slide to just kind of give you a kind of mini advice. One way of reducing risk for statin muscle side effects may be taking statins with food. So currently there's no problem whether you take statins with food or without food. And a lot of people take it at nighttime or take it on an empty stomach. The benefit with regards to cholesterol lowering is the same. So there's nothing wrong with taking it with food. But we had carried out a study that showed that, in fact, there's two things that is helpful to know. One is that certain statins, including Rosuvastatin, the blood concentration is higher in Asian subjects compared to Caucasian subjects. But that in both groups, the blood level is in fact lower if you take it with food, whether it's high fat or low fat food. So I currently think if you or anyone you know is on a statin, there's nothing wrong with taking it with food because we know when we looked at our own data even of patients taking statins with or without food had no meaning with regards to predicting the dose of a statin the patient was on, and that the LDL-C lowering effect of statins, whether you take it with or without food, is the same. So it looks like since taking it with food can lower the blood concentration of a statin without compromising cholesterol lowering effect, we think it's an easy way to reduce the risk of statin muscle troubles. So that's something I think it's a good thing to remember, because the product monograph from Health Canada or FDA has no problem. There's no comment about with or without food. So I think people should take their statins with food. So this is just a brief summary that talks about 2C19 and drugs like Clopidogrel, as well some summary about the statins, and like I said, with food. So I do think patients on Clopidogrel or about to start Clopidogrel having CYP2C19 genotype may be potentially helpful with regards to ensuring that it is working well. And one thing to remember is that CYP2C19 genetic variation is much more common among patients of Asian ancestry. So that in fact, doing the genotyping in those patient cohort may be very useful, or maybe those patients might need to go on ticagrelor if you want to reduce the chance of suboptimal response to Clopidogrel and you don't proceed with the genotype testing. I'll now change gears a little bit about an effort that took us about 10 years, really an example of translating research into patient care right here in Ontario. So this relates to this gene called DPYD, or dihydropyrimidine dehydrogenase. This is the rate-limiting key enzyme that's involved in the deactivation of chemotherapy medications 5-fluorouracil and its oral medication called capecitabine. All of the oncologists that prescribe these types of chemotherapy medications always fear this DPYD deficiency. So the protein itself is called DPD. The gene is called DPYD. About 1 in 15 have a partial deficiency and typically require dose reduction. Otherwise, they experience severe toxicity. About 1 in 1,000 have a complete deficiency and can often be fatal even after a single dose. So currently, we carry out DPYD testing for all cancer patients prior to capecitabine or 5-fluorouracil at our medical center, and we have done this for nearly a decade. So I'll show you a case where, this has really helped to save a life. So this is an 87-year-old male who came in with profound anemia, required transfusion, identified with the rectal cancer with metastatic liver lesions seen in our clinic, was being planned for chemoradiation. And with regards to chemotherapy, capecitabine was being planned. We carried out the testing, and the patient, in fact, was predicted to be deficient in DPD enzyme activity. And we currently follow CPIC guidelines, and we recommended an alternative drug because it can be potentially life-threatening. Or if they do proceed with 5-FU capecitabine, a markedly reduced dose would be needed. But in this rare case, it would be much safer simply to select an alternative medication. So when this happened, I notified the referring oncologist. I called the patient, and the oncologist actually eliminated or removed the pre-ordered capecitabine drug order in our electronic medical records. And the oncologist decided to proceed with a second-line agent, in this case, reltitrexed. And we know for this patient, there would have been a lethal event had the patient received even a few doses of capecitabine. So in 2018, I had requested that DPYD testing to be a standard of care, and this was requested to Ontario, Health Quality Ontario, where they then carry out in-depth review of the literature as a part of a health technology assessment. And in August 2021, Ontario Health Technology Advisory Committee, after reviewing all the evidence, published a final recommendation that's recommended that the DPYD genotype testing be funded publicly. And just a few days ago, on 19th of April, 2023, the province actually provided funding now that will be available to all Ontarians with regards to DPD deficiency testing. And I think they have shared all of the information to practicing oncologists. So now all of the oncologists in Ontario will be able to order DPYD testing through their hospital labs, which will then send to some of the core labs in the province that will do the testing. But in principle, this will be a test that's available to every Ontarian who needs this type of chemotherapy medication. So really, in essence, you know, our team has been here since 2006. So we have really moved from this notion of trial and error and you know, unpredictable response or adverse reactions to this personalized medicine-based approach, which often includes real-time genotype testing. And we have worked very hard to integrate this as a part of routine patient care with the goal of patient safety, improved health economics, and optimal drug efficacy that then leads to desired outcome. So this is just a little bit of a kind of a timeline that kind of shows you where we started from in 2006, in which we really started various types of clinics, created various types of technologies, and behind the scenes, a very large team that helps me to run this program. Over the years, we have actually had some provincial recognition for innovation. And we have implemented personalized medicine as a hospital-wide program. We continue to work with our LHSC, ITS, and EMR experts in terms of a further integration of personalized medicine into our EMR. And I do think we are increasingly being recognized as a regional and provincial center of excellence for personalized medicine. So it's really quite gratifying. So if you're ever wondering how we actually kind of provide service and how this type of service can be accessed, within our hospital public website, it actually has a web page that is listed under various programs that are available at LHSC. So I put the web link there. And within that, there's multiple pages, but it kind of goes over who we are, what we do, and the type of testing that's available. And as we now have various types of secure web-enabled virtual care consultations capable, that we do think some of our patients who need our service may be able to benefit from our approach virtually. I have kind of noted to Kathy that for the moment it may require a liaison person who will help with the shipment of a blood sample from remote site to my research lab. But other than that, the service itself could theoretically be feasible to reduce, especially remote area patients from driving all the way down to London, Ontario. So some of the commonly requested genotype testing includes persistent GERD for PPI therapy. Some patients for CYP2C19. We talked a lot about intermediate and poor metabolizers for clopidogrel, but 2C19 is really important for the metabolism of proton pump inhibitors. And in fact, for CYP2C19, some patients have genetic makeup that makes this enzyme more active. And they're called rapid or ultra-rapid metabolizers. In those patients, they metabolize PPI medications too quickly, and they do not benefit from standard dose of PPI medications. So by testing for this, it can provide some reassurance with regards to whether the patient is on the right dose of a PPI medication, particularly when they have to take PPIs for long periods of time for persistent or refractory GERD. We do have some testing capable for some antidepressant medication dosing and selection by carrying out CYP2D6 and CYP2C19 genotype testing. We do recognize this is a very tough area in that depression and treatment of depression is very complex, and it certainly requires psychiatrists to be involved or family physicians who are very comfortable with managing depression. But sometimes carrying out a pharmacogenetic testing in 2D6 and 2C19 can provide some additional insights to SSRI or tricyclic antidepressants that might be helpful with regards to dosing or selection of antidepressant medications. We already talked about clopidogrel and statins. We do see a large number of patients for azathioprine metabolism, and currently we carry out testing for TPMT as well as another enzyme called NUDT15. In addition, we also have a testing that we carry out for identifying patients at risk for azathioprine-induced pancreatitis. So for azathioprine, we actually carry out testing for three different genetic markers, and our referring physicians value all of that. So we do all of that just so that they're more confident about whether patients should be on azathioprine. For our GI doctors specifically, they also often like to have a very new HLA testing marker that can help with identifying patients who might be at a higher risk for autoantibody formation during TNF-alpha blocking biologic medications such as infliximab or adalimumab. And by having this information, they're more comfortable about whether some of their patients might require combination therapy for their Crohn's or ulcerative colitis, or they might be able to go with a monotherapy using a biologic. So we do see quite a large number of patients for that. And for some of our breast cancer patients on tamoxifen, we carry out CYP2D6 genotype testing as well as we measure the blood concentration of the active metabolite endoxifen. So tamoxifen, kind of like codeine in a way, is not the active drug. It is converted by CYP2D6 to its active metabolite endoxifen. So by carrying out the genotype testing as well as measuring endoxifen level, sometimes they can provide reassurance for our patients that the blood concentration is within a normal range, because some patients do struggle with a lot of adverse effects, and sometimes they wonder whether it's working. So by having these type of things done, we do find it provides some additional level of reassurance, because most of the patients on tamoxifen typically have to take it for 5 years or sometimes longer than 5 years. So finally, the last slide that I have is just to thank our donors as well as funding agencies. I've been very fortunate to have funding from our LHFC Auxiliary, who has donated large sums of funds or committed large sums of funds to our program to help our patients, as well as Wolf Medical Research Chair in Pharmacogenomics, which really helps me in terms of being able to dedicate more time to research, as well as grant funding agencies such as CIHR and Ontario Research Fund from the Ontario Ministry of Science and Innovation. So that's kind of my last slide. I'm going to, I guess, discontinue the share, and I'm happy to answer any questions that you may have. Thank you.
If anyone has any questions, just go ahead and unmute yourself.
I was just curious if you know off the top of your head, like how much most of these tests generally cost to run, and then also what your expectations are in the coming years in terms of like how quickly this might come to family practice or a community hospital in terms of, you know, testing for the clopidogrel factors there. And yeah, any of your thoughts there?
Right. That's actually a very good question. So we know there's a lot of pressure on the healthcare system, even in Ontario, with regards to what should be done in terms of pharmacogenetic testing. Partly because the tests are becoming simpler and easier and more widely available. As you may know, there's a lot of direct-to-consumer testing, such as 23andMe, so people can do the testing themselves, and cost is quite modest. Some of the, I think, insurance plans, retirement plans offer pharmacogenetic testing as like one of the packages that people can have. So I think, and also I think there are some pharmacies that offer pharmacogenetic testing for a fee. So the testing is going to become more widely available. But the key question relates to, is it clinically meaningful? And does it provide additional value for our patients? So I think Ontario government, certainly Ontario Genetics Program, is quite interested in better understanding what type of testing should be more broadly available, what is cost effective and helpful for our patients and the province. Because you can imagine a lot of information that is not clinically meaningful or actionable could result in a lot of unnecessary doctor visits. So that is coming. Typically for pharmacogenetic testing, I think commercially available tests is highly variable from, I don't know, $150 to over $1,000. And I believe some of these tests are available through commercial companies such as Life Labs, as well as other companies. But we do think in the future, as clinical utility of these tests become clear, that presumably government will consider funding very specific tests. So that will not be an issue. Currently, I think panel testing or pharmacogenetic testing in principle from various laboratories, I would think would be in the $100 to $200 range for the testing to be completed. All of our patients that we have seen, as we are a research program funded by research funding and donors, whether they participate in our research program or not, we never charge anything to our patients. But I do think in the future, much of this type of information may already be available, but interpreting the information may be quite overwhelming for a lot of healthcare providers. So we think experts in the field, including ourselves, we are clinical pharmacologists that specialize in drug metabolism and pharmacogenetics, may be able to help with a subset of patients with additional complexity with regards to consultation and advice. So that's why we think having this conversation about clinically meaningful tests, turnaround time, and a type of services that's available is useful, because we do think for this field to really be systematically become successful, that in Ontario, we need to be thoughtful about the structured introduction and assessment, because cost of the test will be low, but looking after the result of the test may be very difficult. And I don't know how many of you have actually seen the reports that are generated by 23andMe or other companies. They will give you reams and reams of results with possible things that could be considered. But you can imagine you really need to understand the patient condition, type of illness, severity of illness, indication for those medications, availability of alternative medications. Those kind of things need to be, and that's where I think physicians have an important role, because otherwise patients will then, come to their family physician saying, well, this report says I shouldn't be on this, I should be on that. But genetics is just one component of variation response. There could be a huge impact of drug interactions. There could be impact of liver function, kidney function, age. So this is where I think clinical input is so important at multiple levels. But we do think, our team and others like us should be available for the province to help with a more complicated scenarios, because at the end of the day, I think treating physicians would like to have, solid decision-making process and not read 50 pages of reports, because all of us have genetic variations. But what does that mean for specific drugs?
Very interesting. Thank you very much for that thorough answer.
Any other questions? Not hearing anything. But I'm sure Dr. Kim would be available if you thought of something afterwards. Okay, well, thank you everybody for coming to our rounds, and thank you very much, Dr. Kim, for presenting today. That was a very fascinating topic. I'm certainly glad we invited you to come and present. And our next rounds will be May 5th, and it will be with Dr. Joan Sari, who will be presenting on migraines and safety-sensitive occupations. We'll wrap it up.
Right. Thank you very much. I enjoyed the opportunity.
Dr. Kassem?
Yes, I'm just saying thank you. Very informative.
Thank you.
Thanks.
All right, I'll let you guys go. Take care. Have a good afternoon.